Stroke volume is about 70 to 90 milliliters in a resting man of average size in the supine position. It is the amount of blood pumped out from each ventricle per beat. Stroke volume equals the end-diastolic volume minus the end-systolic volume. End-diastolic volume is the blood volume in each ventricle at the end of the diastole. It equals 130 milliliters, and it is affected by the venous return. Cardiac output is the amount of blood pumped out from each ventricle per minute. In a resting, supine man, it averages about 5.5 liters per minute, 80 milliliters x 70 beats/min closing parenthesis. End-systolic volume is the volume of blood in each ventricle at the end of the systole. It is about 50 milliliters. It is affected by the arterial blood pressure and cardiac contractility. If the heart rate increases, the cardiac output increase. However, when the heart rate increases so much to the extent it shortens the diastolic time, cardiac output can decrease rather than increase. This is explained on the basis that the normal diastolic time in a person with an average heart rate of 70 beats per minute is half a second, so coronary and heart filling takes place. Too much increase in heart rate can shorten the diastolic time and decrease the end-diastolic volume, the force of contraction, and stroke volume, and decrease cardiac output. If the stroke volume is increased, it would increase the cardiac output, provided that the heart rate is unchanged. The stroke volume depends on preload, afterload as well as myocardial contractility. Factors affecting the cardiac output: the heart rate, venous return, preload, efficacy of cardiac contractility, arterial blood pressure, afterload, end-diastolic volume, venous return, preload, blood volume, and viscosity. When the venous return is increased, the cardiac output will increase. When an extra amount of blood flows into the ventricles, the cardiac muscle itself is stretched to a greater length. So, the muscle will be contracted with increased force, and the stroke volume is increased. Stretch of the right atrial wall increases heart rate by atrial stretch receptor reflex, and increases the cardiac output. Factors affecting the amount of blood returning to the heart likewise influence the degree of the cardiac filling during diastole. There are several mechanisms that help to return venous blood back to the right atrium. Venous return is directly proportional to the pressure gradient between the right atrial pressure and mean systemic filling pressure, PSF. Systemic filling pressure depends on blood volume and venous compliance. There is a direct relationship between blood volume and PSF. The greater the blood volume, the higher the PSF and vice versa. The more compliant the veins, the lower the PSF and vice versa. So, constriction of the veins reduces the size of venous reservoirs, decreases venous pooling and increases venous return, in the supine position. The pressure gradient between PSF and RAP tends to return the blood back to the heart. This factor disappears in a standing position due to the effect of gravity. The other factors help to maintain the pressure gradient and hence venous return in a standing position. Skeletal muscles exert a muscle tone that compresses the veins and allows venous return, so they are called the peripheral heart. This is enhanced with muscular exercise due to increased muscle contraction. Arteriolar dilation increases venous return, while arteriolar constriction decreases venous return. Only 10% of the capillaries are opened under normal resting conditions. This maintains the venous return. If the capillaries open at the same time, blood accumulates in the capillaries and no venous return would occur. Valve pressure in the veins prevents the blood from returning back and keeping it directed to the heart. The valves are not present in the big veins, very small veins, the veins in the gut and brain. Inspiration increases the intrathoracic pressure negativity and the venous return. Sympathetic stimulation causes constriction of the veins plus the other blood reservoirs, pulmonary veins, spleen and veins in the gut. So, the venous return, the end-diastolic volume, the stroke volume and the cardiac output will be increased. Myocardial contractility is affected by neural input, calcium availability, the preload, Frank-Starling law, and changes in cardiac rate, HR, and rhythm. Myocardial contractility is depressed in heart failure, hypoxia, and acidosis. When the sympathetic nerves to the heart are stimulated, the force of contraction increases, circulating epinephrine and norepinephrine augment. The positive inotropic effect of norepinephrine is liberated at the nerve endings, when the strength of contraction increases without an increase in fiber length. More of the blood that normally remains in the ventricles is expelled, that is, the ejection fraction increases. Parasympathetic stimuli have the opposite effect. A high heart rate, pacemaker-induced, produces a small increase in contractility. However, with increased heart rate to the extent that shortening the diastolic time will interfere with cardiac filling and cardiac contraction. Starling mechanism and sympathetic stimulation increase myocardial contractility, but they do not use the same pathways. Sympathetic stimulation makes its effect by increasing the amount of calcium entry from the extracellular fluid, so increasing the intracellular calcium, while the Starling mechanism increases the sensitivity of the myocardial fiber to whatever calcium may be there. When arterial blood pressure increases, it will interfere with the force of contraction. This causes the initial decrease in the stroke volume and cardiac output, and the end-diastolic volume of the next beat increases, which leads to increased contraction force and stroke volume and cardiac output. When the heart rate increases within limits, it increases cardiac output. The heart rate is affected by autonomic nerves, with sympathetic stimulation increasing the rate and parasympathetic decreasing it. When blood volume increases, it helps the venous return, while hemorrhage decreases the venous return and cardiac output, and increased blood viscosity retards the venous return. But in conditions of low blood viscosity such as anemia, the venous return and cardiac output are increased. Thank you for watching. If you like this content, don't forget to like, subscribe, and share this video.